most important in orthopedic surgery, because all the operation are done by peripheral nerve block or regional block. These are brachial plexus block is two types mainly. And the one is supraclavicular block. Supraclavicular block is done due to forearm surgery, and interscalene block done for arm surgery and clavicular surgery or shoulder surgery. So first you have to know about the brachial anatomy of the brachial plexus. Brachial plexus forms by C5, C6, C7, C8 and T1 root or ventral rami of these roots. First, it's formed by the root, then trunk, then division, then cord. Any of you know about the details about the brachial plexus anatomy? First, the ventral rami of the C5, C6, C7, C8 and T1 from the roots. Then all have the two divisions. All the C5 and C6 anterior division form the upper trunk, and C7 only one, and C8 and T1 middle trunk and lower trunk. Then upper trunk, middle trunk and lower trunk. In every trunk have two division, anterior division, posterior division. All the anterior division forms the lateral cord, and all the posterior division form the posterior cord, and C8 and T1 having the anterior division forms the lower trunk, lateral cord. So lateral cord, posterior cord and medial cord. Posterior cord mainly forms radial nerve, lateral cord mainly forms median nerve, and medial cord mainly forms ulnar nerve. And there is many division of the roots, of the trunks and the cords. Do you any have now any division, any branches of the root, any cord, any division? Do you know any branches? You should have to study. First, you should have to know about the anatomy. Then you know its clinical implication and what will happen if we give the block. Okay. So first, roots have two divisions: dorsal scapular nerve and nerve to serratus anterior. And trunk have mainly upper trunk have the two division: nerve to serratus anterior and dorsal scapular nerve. And the cord having lateral cord, medial cord and posterior cord all have many division, like lateral cord having LML, like lateral cutaneous nerve, musculocutaneous nerve, lateral cutaneous nerve of the forearm. You should have to study first, then you can understand. So anatomy you should go through about details about in book. Then I will just tell you about the anesthetic implication and the process and what will happen if there any complication happen. First, you should have to know if there is any fracture or any problem in the limbs, upper limbs. Then we do two types of block: supraclavicular block and interscalene block. Supraclavicular block, how to surface marking, how to identify that if we know the anterior triangle of the neck, there is a two division: anterior cutaneous muscle and medius cutaneous muscle. Do you know the triangle of the neck? You should have to go through about details in book. Okay. Then if there is a part of the cord present between the anterior cutaneous muscle and medius cutaneous muscle, that is the surface marking of the supraclavicular block. So you have to identify the nerve, the cord of the brachial plexus in between these muscles. So how to approach to or identify to the nerve? Three types One is blind approach, one is nerve stimulator approach, third is ultrasound-guided approach. First, you have to know blind approach. Blind approach is very confusional. Sometimes blocks will happen or sometimes it's failed. So how to start blind approach? Blind approach, you have to identify the lateral cord or medial cord or posterior cord by a needle passes through the in between scalenus muscle, and you have to try to identify if there is any tingling or numbness of the limbs. Supraclavicular block is done for arm surgery. Any surgery below the wrist joint. So you have to identify, is there any tingling numbness below the wrist joint? If any tingling numbness is happening below the wrist joint, then you have to give the local anesthesia. What type of local anesthesia we have? Do you know? Lignocaine and bupivacaine. So lignocaine, plain lignocaine or lignocaine with adrenaline? Plain lignocaine or lignocaine with adrenaline? Why? তাহলে এখানে কি দেওয়া যাবে অ্যাড্রিনালিন দেওয়া যাবে কারণ কি এন্ড অর্গান নয় গুড সো you can give lignocaine with adrenaline or bupivacaine. The dose of the lignocaine with adrenaline is 5 ml per kg body weight and bupivacaine 0.5% is 2 ml per kg. So you have to give the drug at about 40 ml, 10 ml lignoadrenaline and 10 ml bupivacaine. Then after the giving the drug, you have to identify if there are any motor and sensory loss. First, motor loss will happen, then sensory loss will happen. So you have to identify that, then you can start the operation. Other process is nerve stimulator approach. Nerve stimulator is a thing that a current passes through the nerve, then the fasciculation or myoclonus will happen at the below wrist joint. Then you have to identify that this is the fasciculation, so you have to give the nerve, give the drug. Other is approach is ultrasound-guided approach. Ultrasound-guided approach, you have to start with ultrasound curve probe. Then you have to identify the scalenus muscles, trunk, roots of the brachial plexus. Then you have to give the drug. Now complications. Complications are Horner syndrome. Do you know Horner syndrome? Good. So what are the sign of the Horner syndrome? It's like unilateral. Good. Meiosis of the pupil, ptosis, congestion, and hearing. Good. So these are the analysis. These are the complication of the brachial plexus block. If there any complication will happen like Horner syndrome, then you have to identify that the drugs already you have given the highest dose, then you should not give the more drug. Other like pneumothorax. What is pneumothorax? Here in the dual cavity. So what will be the management or approach in a patient with pneumothorax? If just you given brachial plexus block and pneumothorax is happened, but patient didn't give any complaint about it, how to identify? Any other? Suppose you have given brachial plexus block, surgeon doing operation and immediately patient complaining that patient having respiratory distress. So what will you do that time? ICD that time. Oxygen কখন নাইমোথোরাক্সে অক্সিজেন দেবো আর কখন নিউমোথোরাক্সে চেস্ট ড্রেন দেবো আর কখন নিউমোথোরাক্সে নিডল প্রিক করবো। Good. Less than 2 centimeter. Less than 2 centimeter hole, wait and watch, high flow oxygen, and maybe you can give needle only, needle pitch, then no problem. If there is more than 2 centimeter and if there is a lung collapse, significant lung collapse. valve মানে কেন না valve না, what is it? জলের মধ্যে রাখা হয়তো কেন? রাইট, গুড। আর 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 চেস্ট টিউব মানে ঠিক আছে, চেস্ট টিউব দেওয়া হলো, ওয়াটারের মধ্যে কেন রাখা হয় অপোজিট পোর্শন? স্যার যে ইয়াটা বেরিয়ে গেছে যাতে আবার বাইরে থেকে এয়ার না ঢুকে যায়, আরো থোরাক্স বাড়িয়ে দেবে। So you have to give water impregnated tube at opposite side. So আর হচ্ছে লাইক যদি লোকাল সার্ভাইকাল ইঞ্জুরি হতে পারে, লোকাল নার্ভ ইঞ্জুরি হতে পারে, and maybe complete spinal anesthesia. If you can give drug to the any subarachnoid space during the brachial plexus block, the whole body will be total spinal anesthesia will happen, and patient saturation will drop, patient BP will drop, everything. Patient will be immediately endotracheal intubation should be done, and vasopressor support will be given. So this is the brachial plexus block. Do you have any question? তোমাদের এখন কি পড়ানো হচ্ছে? মেডিসিন, সার্জারি, গাইনি আর আইএনটি যোগ করে দিয়েছি, আমাদের সময় ছিল না। এখন পরীক্ষা কখন তোমাদের? পরীক্ষা কখন? ফাইনাল ইয়ার